Good evening, everybody, and welcome to the Open Hand webinar for the month of May. It's lovely to have you join us. The webinar series is brought to you in association with the University of the Witwatersrand in Johannesburg, South Africa, and the Society of Hand Therapists. Today's webinar, we are going to be looking at the primary care of hand trauma and general principles for managing acute hand injuries. If this is the first time that you're joining us, the Open Hand webinar series usually has a focus on hand therapy, and Open Hand is really passionate about increasing access to basic hand injury care and equipping the therapists that provide this care. But we're aware that incorrect or inadequate management of injuries often lead to secondary complications that make therapy very tricky along the line and can impair patients' function and have very disabling effects. So that is some of the reasons behind tonight's webinar. And we're very grateful to have two hand surgeons speaking to us this evening. First of all, Dr. Pieter Jordaan will do a simple and systematic approach to assessing the injured hand. And then Dr. Kruger will address first do no harm, basic principles for the management of acute hand injuries. Just a sharing of a resource. There are two very useful applications available that help us in managing acute hand injuries. Firstly, the Anatomy at Risk application helps you identify what potential structures in the hand may be injured. And then the Hand Surgery Source covers a very broad range of hand diagnoses, the examinations that one needs to conduct, the involved anatomy, and therapy for those particular conditions. So if you're working with acute hand injuries, those are very valuable things to have on your phone. So have a look at those. Then if you have any questions or comments, please feel free to contact us. But without further ado, let's get down to our first presentation for this evening. While Dr. Pieter Jordaan shares his screen, I will introduce him. Dr. Pieter Jordaan, it is a privilege to have you share with us this evening. Dr. Jordaan is an orthopedic hand surgeon and a peripheral nerve specialist in private practice in a city called George in South Africa. He specialized in orthopedics at the University of Cape Town, where he received numerous prizes and awards for his performance during that specialization process. He then went on to complete a number of hand fellowships, firstly at the Martin Singer Hand Unit in Cape Town, then at Wrightington Hospital in the United Kingdom. And then he went on to complete a fellowship, a peripheral nerve and hand surgery fellowship in Birmingham. Dr. Jordaan is a fellow of the European Board of Hand Surgeons, and he is a strong supporter of a multidisciplinary team in hand therapy or in hand injury care. So it is a great privilege for us to have you speak. Thank you, Dr. Jordaan. Over to you.
Yeah, thank you. Thank you very much for the opportunity, Kirsty. So whenever I do a talk like this, I'm reminded of Gandalf, and that's just because this is such a vast topic and we've got so little time. So I'm going to try and just touch on a few things. I might not actually go through everything very systematically, but I'll try and touch on certain bits that I realize people struggle with. Just before getting to the nitty-gritty, if you can remember just this slide for this evening, I think you've done well. So the first thing to remember, it's not just the finger. The second thing is everyone's hands are important to them. People need to eat, they need to go to the toilet, everyone needs their hands. And patients often say, I can move my finger, it is not broken. That's a myth. So if you can remember this slide, I'm very happy. So just in terms of the outline, I'm going to cover a few basics of anatomy. I'm going to tell you about the approach to open injuries, and then I'll tell you how I examine nerves, tendons, ligaments, and bones, so basically fractures. If I've got time, I'll cover sepsis, just also very briefly, and then hopefully we can do a few just tips and tricks regarding general approach to hands. So for me, the most important thing is to know your anatomy, and you must know how to examine it. If you know what can be injured, you will know what to look for, and if you know how to examine it for it, you will probably not miss any injuries. I'm going to start with the nerves because I think there's a lot of general misconception about the nerves, or a lot of people get confused. I'll start with the median nerve. All of you know the sensory distribution. Basically, on the volar side, a radial 3.5 fingers. And just remember that the median nerve also supplies the dorsal aspect of the fingers from the middle of P2 distally. Also remember the palmocutaneous branch, which supplies the sensation at the volar base of the thumb. That branches off about 5 centimeters proximal to the wrist. In terms of motor function, it's very easy to remember. The median nerve supplies all the flexor muscles of the forearm, except the FCU and the ulnar 2 FDPs. In the hand, it supplies loaf. So that's your lumbricals, the radial 2, opponent's pollicis, abductor pollicis brevis, and flexor pollicis brevis. Also remember the main branch of the median nerve is the anterior interosseous nerve, which branches about 5 to 8 centimeters distal to the medial epicondyle. And this supplies the FDP, the FPL, and the pronator quadratus. This is important to remember because depending on the level of your injury will determine which muscles are affected. When you get to the ulnar nerve, I'm sure you all know the sensory supply as well. The ulnar 1.5 fingers, volar and dorsal. Just again, remember the dorsal cutaneous branch branches off about 7 centimeters above the wrist. So any injury below that will not affect the dorsal sensation of the hand. Motor function of the ulnar nerve is the reverse of the median nerve, basically. So all the muscles in the hand except loaf, and then the forearm, FCU, and your ulnar 2 FDPs. The radial nerve, sensation you know as well, the dorsal 3.5 fingers, but only to the mid-level, mid P2 level. And this is the only nerve that's got sensory supply in the forearm, and that's the posterior forearm. Motor function, all your extensors. So brachioradialis and ECRL is the radial nerve proper. All the other extensors are the posterior interosseous nerve. So when you've got an injury, this is how we differentiate between a high and a low radial nerve injury. A high injury has got no wrist extension, no finger extension, and no thumb extension. But a posterior interosseous nerve injury is a low injury, and here you will have wrist extension, but in radial deviation, but you'll have no finger and no thumb extension. In terms of sensation of the forearm, the reason I'm putting this in is because often there's confusion about this. So the lateral or radial side of the forearm is innervated by the lateral antebrachial cutaneous nerve. This originates from the musculocutaneous nerve, which supplies as motor function the biceps and brachialis. The medial or ulnar side of the forearm is the medial antebrachial cutaneous nerve. This originates from the medial cord of the brachial plexus. So if you've got loss of sensation of the medial or lateral side of the forearm, the injury is quite high. And then the posterior aspect of the forearm is the posterior antebrachial cutaneous nerve. This comes off the radial nerve, but it comes off very high. It's about mid-upper arm. So just remember that the median and ulnar nerve has no sensory innervation in the forearm. But what you must also remember is that all human beings are different. Only about 40% of people have this nerve anatomy that I've just described. So even though it's only 40% of people, it's still the most common variant. So there are lots of anomalies. In terms of open injuries, just with your general approach, I think when you approach a patient with open injuries, there's always what I call the usual suspect. So you want a good history. What's their previous medical history, their occupation and hand dominance, and the mechanism of injury. And why this is important is there's a big difference between somebody injured with a power tool versus a little domestic accident. And the reason for this is if you're going to refer this patient on and you know that it's just a little steak knife, you can expect just a plain flexor tendon injury. But when it's a power tool, you start looking at injuries like these. And then you start looking at nerve reconstructions where you basically have to graft all the nerves in the hand. And it's nice to kind of, before you go in, have an idea of what you're dealing with. So then moving on, it's the same general orthopedic principles that we always use: look, feel, move. But for me, the most important thing is you really need to know your anatomy well. So if you know what structures can be injured, you will know what to look for. And for me, a thorough neurovascular exam is incredibly important. And do this before you inject local anesthetic. Test sensation, test motor function. Look for capillary refill and turgor, and I'll show you in this photo and the next one why this is important. And look for tendon injuries. You've got to actively look for your tendon injuries. If you look at this photo, this again is a grinder injury. The fingers look pink and you might think they're well perfused, but you can see the soft tissue is kind of collapsed. It doesn't have good turgor. So this patient had both digital arteries on each finger was cut, and it's important to pick this up. The next one, also very important with your vascular exam. Look at the color, look at the turgor, and look at the capillary refill. So a slow capillary refill means there's arterial insufficiency. Often a brisk capillary refill means there's a venous insufficiency. And if there's no good venous outflow, the finger will also die. So if you look at this video, you'll see the middle finger, quite a normal capillary refill, the ring finger a bit blue, but look at that increased turgor and that sudden rapid brisk refill. So that means there's venous insufficiency, and this is a typical ring avulsion injury, and you have to actually go and repair the veins, otherwise you lose the finger. And a lot of people look at it and they say, oh, it's nice and pink, it's got a brisk capillary refill, it's fine. It's not fine. So just look at that very carefully. So just getting back to your anatomy, I know I harp on about this, but to me, this is the most important part of assessing the hand, is knowing your anatomy. So remember, you've got to think skin, you've got to think tendons, extensor tendon, flexor tendon, the intrinsic tendons. You've got to think of the muscles, think of the nerves, think of the arteries, think of the veins, think of the bones and the joints, so i.e. the ligament injuries. And have a very, very low threshold for performing an X-ray. And if I can give you some advice, just always do that X-ray. I think don't skimp on X-rays. And this is an example, a classic mallet finger. Patient comes in. But if you look carefully at this, and I'm not just pointing towards the big dorsal fragment, you'll notice that joint is subluxed. And this is the type of mallet that needs treatment. So if you don't do an X-ray, you'll miss that. So as I said, just always get that X-ray. Ultrasound is usually not necessary. Most of these injuries you look for an ultrasound, you can, with a good clinical diagnosis, get there. And be specific. And the reason for that is my last word just on X-rays. Ask for the anatomical X-ray that you're investigating. If it's the thumb, ask for a thumb X-ray, not the hand. If it's a wrist injury, ask for a wrist X-ray, not a hand X-ray. And get true proper APs and laterals. And just the reason for this is X-ray beams diverge. So in other words, if you get an X-ray of the forearm, by the time the beams get to the wrist, you're not really getting a good picture of the wrist and you'll miss injury. So just, and the same with that mallet, ask them if it's an index finger, can I get an X-ray of the index finger and focus on the DIP joint and please get a true lateral? And then you won't miss injuries like that. So just examining nerves, I'm just going to touch on a few points. So just in terms of the radial nerve, you can see this drop wrist, but just look at the movement there of the fingers. So if you can extend the IP joint, so you can extend the PIP and the DIP joint, that's not radial nerve function. That's ulnar nerve function. Radial nerve function, you need extension at the MCP joints. And that's really important that you look for that. So a lot of people will look at it and say, look, you can extend your fingers if the PIP and the IP joint can extend. That's ulnar nerve function. That's not radial nerve function. Look for MCP joint extension. Then median nerve. Median nerve, if it's a high median nerve injury, so above the AIN, we get the sign of benediction. But remember, it's important, this you get when patients try and make a fist. So when they try and flex their fingers, they can't flex the thumb and the index finger, and they can usually partially flex the middle finger. When you get to ulnar claw, it's the opposite. This is an ulnar claw that you get when the patient tries to extend their fingers. So when they try and extend, they can't extend it. And remember about the ulnar paradox. So in other words, if the lesion is low, the claw is worse. And this is because with a low lesion, your FDPs are still working, which causes a more severe clawing. With a high lesion, with your FDPs knocked out as well, you get a less severe claw. Yeah, so basically in terms of this, you're looking for abduction is when the thumb actually elevates towards you in this picture. Opposition is what you get when you move the thumb towards the little finger and the thumbnail is parallel to the palm. That's true opposition. So that's what you look for in a low median nerve injury. Look for thumb abduction. So in other words, lifting your thumb away from your palm like that. This is opposition. This is not opposition. Then when you examine the tendons, I'm just going to basically go through some of the things. So firstly, the C-slip or the central slip is something that's often missed. And this is where you get your boutonniere deformities or your boutonniere injuries. Now, a true boutonniere is actually pretty rare, and it's important to differentiate from a pseudo-boutonniere. So how I examine this is the first one. I get the finger in full extension, and I try and get the patient to apply a resisted extension at the PIP joint. And then I get them to flex the PIP joint to 90 degrees. With the PIP in 90, like the picture on the left, I try and get them to extend against resistance, and you then test the tone in the DIP joint. If the DIP joint is supple, then it means the central slip is intact. If the DIP joint is not supple and it's stiff, then you know the central slip is not intact. And it's important because with a central slip, you want to immobilize it if it's a central slip injury. With a pseudoboutonniere, which is usually a collateral ligament injury, you want to move them early. But basically, when you examine an EPL, this is the best way to examine EPL. Get the patient to put their hand flat on the table, and then you ask them to retropulse or elevate the thumb off of the table. You can clearly see the EPL over there. And this is the best way to test for EPL. Don't just get them to flex and extend the IP joint. FDP and FDS, basically what you do is you immobilize the DIP joints of the fingers you're not testing, so in extension, and then you get them to flex at the PIP joint. With the FDP, you'll basically apply pressure over the middle phalanx and then get them to flex the DIP joint. So I just want to apologize because this is not a true sagittal band injury, but this is a patient with a chronic sagittal band attrition. But it demonstrates it very well. So sagittal band injuries, the classic boxer's knuckle, you get a sagittal band tear. The EDC subluxes to one side, and this patient was told she's got a trigger finger initially, but you can see as she tries to extend, you can see the EDC is sitting in the ulnar gutter. She cannot extend, it locks, and as she tries harder, the EDC reduces into the middle. So always look for this and remember about the sagittal band. When looking at ligaments, it's important when you examine finger MCP joint collaterals to examine them in flexion and about 90 degrees of flexion. The reason for this is that the metacarpal head is round, so you get a cam effect. With the MCP joint and extension, there's a lot of sideways motion. As soon as you flex it over the round metacarpal head, the ligaments tense. And once they tense, you can't move it as much. You can see there I'm testing the healthy side, minimal side-to-side motion. This is the injured side, and you'll see as I go further how the patient feels that pain. And you can see there's no stop there. So that's a complete rupture of the collateral ligament of the finger. With the thumb, just remember to examine it in extension, the thumb MCP joint, and in 20 degrees of flexion. So that's quite an important thing to remember. And don't forget the CMC joint. So in other words, people tend to forget that the CMC joint can also get injured. Don't forget that. When you're looking at fractures, it's important to remember that you should not use the position of the nail. So rotation is the most important thing that I look for clinically because this is not something you can see on an X-ray. So the X-ray is important to look at the fracture alignment. Clinical examination is how you determine rotation. And don't use the nails. It's not reliable. Generally, what you should do is you should flex the joint distal to the fracture 90 degrees and you look for overlap. This, in a normal hand, roughly all fingertips point towards the scaphoid tubercle, roughly. This you can see rotation. On the left-hand side, it's the ring finger fracture is rotated towards the ulnar side. So no overlap here, but quite a big gap. And after the fracture is fixed, you can see it's all well aligned. Remember, rotation is a clinical diagnosis. Just a few words on the wrist. I don't think we have time to really go into the wrist examination, but try and avoid the diagnosis of a wrist sprain. Do a focused examination and remember your anatomy. So look for scaphoid fractures, look for triquetral fractures. Remember the scapholunate ligament that can be injured. Remember the distal radial ulnar joint. An X-ray can look almost normal, and you can have a distal radial ulnar joint dislocation. So if somebody cannot prone supinate, you've got to think about this. And also remember the hook of the hamate fractures. They can easily be missed if you don't look for it. So again, anatomy, anatomy, anatomy. Just a few slides on sepsis. This is obviously severe hand sepsis that you can see here. With sepsis, have an aggressive approach. Cellulitis of the hand is unusual. Yes, you get it, but it's unusual. Normally, there's an abscess somewhere. So if you suspect cellulitis and you get no or minimal response after 48 hours of antibiotics, there's probably an abscess somewhere that needs drainage. Don't change the patient to a different course of antibiotics. No response at 48 hours, they need to be referred and they probably require surgery. If they present to you longer than 48 hours after onset of symptoms, you've got to strongly suspect that there's already an abscess somewhere. Obviously, there are exceptions to the rule, but I think be aggressive with sepsis. The photo I showed you is a patient who had what started as a paronychia. She's a diabetic. She got put in one course of antibiotics, then she got put in a second course of antibiotics, and then she got put in a third course of antibiotics, and she ended up losing a finger. And remember, ultrasound is not reliable in the hand to look for abscesses. And especially if with a flexitina synovitis, it's a clinical diagnosis. So just a couple of tips and tricks, specifically splinting and casting. If possible, you must always leave your MCP joints free for motion. So they must always be allowed to move unless there's a very specific indication. And never, ever splint your MCP joints in extension unless there's a really good reason for it. Your best position for the hand is slight extension at the wrist, about 60 degrees of MCP joint flexion and the IP joints in extension. So this is a good photo showing you just roughly where you want your cast. This is a volar slab below elbow, and you can see that distal palmar crease is free and the patient can flex his MCP joints fully. This is what you want. Just to show you a finger tourniquet. So this is how I often do a finger tourniquet. I cut a finger of a glove. I wrap it around the finger with the artery forceps, and then I start spinning it. Once I've got a lot of tension on it, then I clamp it, and there you can work on a bloodless field. Now, you might look at this and say, this is a lot of effort, but I'll show you two other pictures. There's a one that you can also use. There's another one that people use. Don't use that one. If you cut off just the glove and you roll it onto a finger like that, it's not easy to see that, and you can miss that. And I have seen patients who had finger tourniquets like that applied that was forgotten on, and they end up getting necrosis of their finger. So on the left-hand side with a whole glove on, a patient won't walk out with it like that, and they'll definitely not walk away home with an artery that's still attached to their finger. So this is for the South Africans who will understand this phrase, but in terms of localized lac, it just means you can use adrenaline in the finger. It's safe to use adrenaline with lignocaine if you do procedures in the hand, but just check for other contraindications. But generally, it's safe. So in conclusion, know your anatomy. That's very, very important. Do a thorough clinical exam, and you must actively exclude injuries to all the structures that you suspect can possibly injure. Have a very low threshold for X-ray, and just always get that X-ray, and make sure you get the right X-ray. Remember to always remove rings early. The worst thing is to see an X-ray of an injured hand with a ring that's still on a finger. As soon as that patient comes in, remove it as quickly as you can. Always examine the contralateral limb. God gave us a blueprint, so you've always got something on the other side that should give you what is normal. And remember, people differ vastly in their laxity and nerve supply and what their limbs look like. And always immobilize limbs in the correct position. Incorrect immobilization can really lead to long-term problems. And MCP joints that are left in extensions, very difficult to get to flex. Below elbow cast that's too long often leads to swelling and long-term pain if it's not done correctly.
Thank you, Dr. Jordaan, for a brilliant presentation. I think we all wish that we knew our anatomy better, and there really is no way around not knowing your anatomy. But thank you for really giving us some great guidelines in terms of a proper examination of the hand. So thank you so much. Then our second speaker for this evening, who will focus on the management of some common or principles of management of acute hand injuries is Dr. Neil Kruger. He is a hand and upper limb specialist, and he consults the Martin Singer Hand Unit at Kruger Hospital in Cape Town, and also works in private practice in Cape Town. Dr. Kruger has got 3 master's degrees, 2 from Oxford and 1 from UCT, and he also works as a senior lecturer at UCT, where he fulfills numerous teaching and research roles. Dr. Kruger, thank you for your time, and we look forward to what you have to share with us this
evening. Chris, thanks very much, and I just want to say it's a real privilege actually to I've been looking at the number of participants, and I'm gobsmacked by what you guys have achieved here in terms of having 360 people on this webinar. Pieter, thanks very much. I'd actually really like to echo what he said. It's nice that through our separate pathways, a lot of what he said really resonates with me in terms of really knowing your anatomy. Definitely get an X-ray if you're unsure at all. And also, I'll touch on a couple of the other basic principles that I think he's really hit the nail on the head. Basically, I'm gonna go through just some of the common hand and wrist fractures and their acute management, and then in terms of just recognizing the common hand infections and basically what to do. Again, you can be inundated with a complete barrage of information, and you can go down a rabbit hole just in terms of nail bed injuries, in terms of what to do. So I'm going to try and broadly keep it very, very straightforward and simple, sticking to distal phalanx fractures, P3, P2, middle phalanx fractures, P1, proximal phalanx fractures, your metacarpals, carpals, and then your wrist fractures. And so I'm going to go through P3, P2, P1, your metacarpal fractures, and then your carpal bone fractures and dislocations, and what are the bad ones that you must recognize. And again, I'll touch again on the importance of getting X-rays and knowing your anatomy. Just simple distal radius and ulnar fractures, your dislocations, and your tendon and nerve injuries. Pieter has really nicely highlighted the clinical exam, and I'd like to echo, it is so super important to make sure that you put hands on your patient. You feel where the swelling is there a collection, where the pain is, in terms of, most of your fractures and things you can actually diagnose without an X-ray, in terms of just knowing exactly where the pain is and where your surface anatomy is, and then correlating that with with a mechanism of injury. Particularly, I'd like to highlight, if you cannot see a fracture but there's pain in your anatomical snuff box, which is that nice triangular shaped structure between your first and third compartments on the radial side of your wrist. If you've got pain in there and you cannot see a scaphoid fracture on X-ray, just please make sure that you immobilize the patient just for 7 to 10 days. Bring them back at about 10 days, re-examine them and re-X-ray them, as you might have missed a scaphoid fracture in that, from that side. But let's just start. Let's just start with the P3 fractures. Sorry. So these are super common. Okay, your crush injury to your fingertip, either the electrical saw's taken it off, or it's been slammed in a car door, or something heavy has fallen on it. So broadly speaking, in case you don't have the red dot that you can see the fracture there, often there'll be an injury to the nail bed. Often there'll be an injury to the actual pulp of the finger with an underlying fracture. It's either open or closed. If it is open, again, apply your broad principles of just do a ring block, wash it appropriately, debride it. It doesn't really often need to be an extensive debridement, but you really need to just identify what structures are injured and then stabilize if needed. So if it really is an unstable fracture and it is amenable to a single K-wire, it is important that open fractures get managed by a good thorough washout, stabilize with a K-wire as is needed, and then some antibiotics in terms of 2 grams of cefazolin, and then a good check in 3 or 4 days' time, just to make sure that there's no infection that's happening. You need to then repair the nail bed, depending on what setting you're in. I know that there's a wide spectrum of people in terms of their experience on this webinar. And so if you do have an open fracture, I do recommend that you refer it to an appropriate institution in terms of managing it in that way. If it is closed, it's either a soft tissue or a bony mallet or a pilon type injury, or it is simply a crush injury where there hasn't been a breach of the external skin. And so it's important that you need to identify these. This again is very important in terms of getting an X-ray. So what Pieter earlier mentioned, he showed you a nice lateral of a large bony mallet fracture, and that large bony mallet fracture caused the distal failings to sublux volally, and that is one that does need surgery and needs to be managed acutely appropriately. Again, you need to do a nail bed repair. For those of you that are doing nail bed repairs, a 6-0 chromic or a 6-0 vicryl rapide, or any form of absorbable suture that just approximate the nail bed will allow the best possible chance of that nail growing out nice and evenly, with no ridging. Again, you need to determine the viability, and again, I'd like to refer back to Pieter's assessment. Capillary refill is quite important. If the terminal tip is really very crushed and there isn't really much chance of salvage, it really is not a very functionally disabling thing to have a distal interphalangeal joint amputation, and particularly in your manual laborers, where you can spend 3 months trying heroics in terms of saving that distal tip. However, they probably have lost their job in that time. And then whereas if you just simply amputated it at the distal interphalangeal joint, they'd probably be back on site in 3 weeks, and they'd be much happier because they have a way of supporting their family. I'd like to very briefly touch on the way that you dress the finger if you are assessing them in casualty. So please, please, please do not use circumferential bandages. What Pieter was saying earlier, I must admit I haven't seen a tourniquet that has been left on resulting in digital necrosis, but I've heard of a case or two where splints have been applied and they've caused complete finger necrosis. I myself have applied one of those those circumferential finger condom type things, and the patient came back with very, very distal tip necrosis. Thankfully, she didn't lose any part of her finger, and that settled and regranulated over time. But it really is a good lesson for us all that you really should not be using a tight circumferential dressing. It is there's absolutely no need for it. The reason physiologically that the finger swells is actually to cause a bit of turgor and a bit of stability. And so a light bandage around the tip that is non-adherent will basically act as an adequate bulky splint. Please do not worry if it does look bulky. And if you are going to need to manage, for example, a mallet finger, or a significantly crushed finger for a period of time, a molded mallet finger splint by a hand therapist once the swelling is down will really do an excellent job. Just simply on P2 fractures. So just a recap on P3, basically, you're just going to bandage it in terms of making sure that it's not that those bandages are not too tight. Broadly speaking, for P2 fractures, use the next door finger as your splint. Obviously, if it is open, we apply the same principles as before. You need to ring block it. You need to define what's injured, wash it, stitch it. If you can see a digital nerve that is injured, again, prior to putting in the ring block, assess either side of the finger for a discrepancy to the touch. Make sure that the finger is well perfused, and then obviously check the FDP and FDS if the fracture is proximal enough. If it is open, you need to refer it on, and it needs to get a washout in theatre, plus minus fracture fixation, depending on what the fracture configuration is and how stable it is. You can always buddy tape P2 fractures to the neighboring finger, again, not too tightly, and refer them on if they are open. This type of fracture, although it is a long oblique fracture and is likely to shorten and displace, and I'd be desperate to put in 2 or 3 screws to make sure that is particularly perfectly reduced and get the patient moving early. It is also appropriate if you are in a resource confined setting to buddy tape this to the neighboring finger and allow that to get tacky over the first 2 weeks, and to just gently get them moving as pain allows, and that is going to heal up absolutely fine. If it is closed, obviously, or intra-articular, extra-articular, you can buddy tape it. If it is intra-articular, please, if it is intra-articular, I do think that you need to refer it on. Some of those do subsequently displace, and they need close monitoring, or potentially they do need surgery. When you get to proximal phalanx fractures, if you take one thing out of this talk of mine, if you get a proximal phalanx fracture, put the patient in a P1 pop. I'll explain to you what I mean by a P1 pop, but this is an excellent way of treating almost all proximal phalanx fractures. Okay, obviously they're open. I'm not going to reiterate it, but they need. Well, I am going to reiterate it. They need antibiotics. They need a washout. They need closure of the wound, and then they may need fixation. Or if you're in a resource constrained setting, you can place them in a proximal phalanx in a P1 pop, proximal phalanx fracture plaster of Paris, and they are going to heal up absolutely fine. All right. You need to define if there are any associated nerves and tendons with your clinical exam, as Pieter has said, and then refer on as is necessary. So this is just a little quite common injury that we see in kids. As you can see, that little finger is splayed away from the midline. It has either been caught on a rugby jersey, or caught on a soccer jersey, or caught on a hockey stick, or while the patient is caught falling. This kind of fracture can be treated really well in the emergency department. All you need is to ring block it, if the patient will tolerate a ring block. You place a pen or a pencil or some form of cylindrical object at the very base there, and then you bend it back towards the little finger, and then you towards the ring finger, and you buddy tape it together. That will usually do the trick. If it is acute, it may reduce quite easily. If it is a day or two, if it is 2 or 3 days old, you may need to put quite a lot of force on that in terms of reducing it. Always get a post reduction X-ray, and then that will remain stable just buddied to the ring finger, and you can gently get them moving. Notes on the proximal phalanx plaster of Paris. This is what it should look like, okay? You need to get the wrist. It is a dorsally based plaster of Paris. It should extend down the proximal forearm, up over the back of the metacarpophalangeal joints, and most importantly, it needs to be pushing the metacarpophalangeal joints down into as much flexion as you possibly can get. It is important for you to realize that you cannot over-reduce these fractures. It is customary for the plaster of Paris to slowly settle over time, and you'll be surprised. You can push as hard as you want to, and often those fingers come back a little bit more extended, but pushing them down like this, where the plaster is lower than you should aim for the plaster being lower than the thumb. That is a good benchmark. You keep the wrist in about 20 to 30 degrees of extension, and you push the metacarpophalangeal joints down. That will, due to the dynamic forces on the proximal phalanx, that will reduce the fracture near anatomically. I have not cut away the bulk of the elastoform bandage in the palm yet here. It is appropriate for the first 3 to 5 days to just allow the soft tissue to settle and keep the patient like this. When you see them in about 5 to 7 days time, or around about 5 days time, cut away all of that soft tissue around, I mean, not the soft tissue, definitely don't cut the soft tissue. Cut away all of the bandage, basically in the palm, to allow the fingers to flex, and they can flex freely in that position. You treat this for 4 weeks in a plaster, and it's going to be absolutely fine. Moving towards the metacarpals, generally metacarpal fractures, the majority of them can be treated non-operatively. So particularly if you're in a resource-constrained setting, single metacarpal fractures can mostly be managed in an ulnar gutter or a volar slab. If they are open, you apply your open principles, but if they are closed, you can slab them, and they can get a nicely molded ulnar gutter slab, and they can again move the metacarpophalangeal joints freely. They are going to heal. They will often heal in very slight flexion with a little bit of shortening, but there is going to be almost no functional inhibition to them. Again, a note on rotation. Please remember what Pieter said in the previous talk, and just check for rotation as the patient flexes. If they are significantly rotated, they do need to be derotated and either plated or screwed or KY, depending on what your surgeon's choice is. Very, very common injury is the Boxer's fracture. This is a fifth metacarpal neck fracture that often looks a lot worse than what the functional problem is. It is obviously very common, and you can accept 60, even 70 degrees of flexion in Boxer's fractures. You just really do not need to operate on them. Most can heal with an ulnar gutter slab or a volar slab, and basically you need to assess them for any intra-articular extension if they are an open fracture, or alternatively, if they really have a significant lag at approximately a week or two, then they may need to be fixed. Moving to the carpus. Now, it's pretty easy to look at a finger and determine as to whether it is, broken or not. Often, so there are 8 bones in the wrist, and often looking at a wrist can be quite confusing, particularly if there's some subtle dislocations or if there's some subtle fractures. So the most important one that we worry about, and by far the most common one that we have in the actual wrist, is the scaphoid fracture. Okay, so again, I've alluded to the anatomical snuff box tenderness. Please take that quite seriously. Place the patient in a volar slab, re-examine them in 10 days' time, and re-x-ray them, as you may have missed a scaphoid fracture. Again, I just want to do a short note here on the surface anatomy. On the picture on the left-hand side is a nice picture that looks at the surface anatomy from the dorsal side. The thumb is on the left-hand side of the image as you're looking at it. The SL joint refers to the base of the scaphoid, where the scaphoid joins the lunate, and there's a very important ligament called the scapholunate ligament that I'll tell you a little bit about in a bit. Your lunate, your triquetrum, above that you've got your hamate, capitate, and then your trapezoid and trapezium. Okay, it is important to feel for those surface markings. Again, if the patient is significantly swollen, just approach them carefully, gently palpate, and you can often tell if there's an underlying fracture by the pain that they experience when you palpate them. On the volar side, you can obviously feel the pisiform, the hooker, the hamate, your scaphoid tubercle, and your trapezium on the volar side. Those are the boundaries of the carpal tunnel, but carpal tunnel is not part of this talk. Something that I'd like you to just look at and be aware of. Again, a wrist sprain is not something that is always that innocuous. It is often an injury to the scapholunate ligament. There is a keystone or a very key ligament complex that sits in the dorsum, or that sits basically between the scaphoid and the lunate. That ligament is very key to proximal carpal row kinematics and function. It is often injured, or it is often the injured structure in an acute wrist sprain. And if not picked up early and appropriately managed, it can lead to dysfunction, stiffness, arthritis, and pain down the line. So I just want to talk to you briefly about the scapholunate ligament injury. This is where knowing your anatomy, and particularly your radiographic anatomy. So if you are working in a setting where you are seeing acute hand trauma in whatever capacity, I would urge you to Google normal wrist x-rays. And you just have to look at a lot of normal wrist x-rays. Learn the angles, learn which bones are which. People miss it all the time. This particular x-ray on the right-hand side was reported as normal by a consultant radiologist. And if you look at it, the scaphoid here, you can see, is high riding. Okay, it is flexed. There's a signet ring sign over here. And although you cannot obviously see, because this is not a stress x-ray, this is a significant scapholunate ligament injury. Okay. It is a common thing, and I would go so far as to say that most don't need surgery. Okay. But it is important that you recognize it early and manage it appropriately. If you have a bad one where the scaphoid is high riding and there are abnormal carpal kinematics or carpal alignment, so where there's an increase in your scapholunate angle, that needs to be referred on and it needs to be repaired. Okay. I just want you to recognize it here. Okay. So they talk about a dizzy. And sometimes it may make one dizzy because it can be quite hard to pronounce. It can also be quite hard to understand. But this is what a dorsal intercalated segment. So an intercalated segment is just one segment between another, and that refers to the proximal carpal row that intersects between the distal radius and ulna and your distal carpal row. Okay, there is instability in this proximal carpal row. Here your lunate is in slight extension. You can see that this little half moon is basically facing towards the dorsal side. It normally should sit at 90 degrees. The volar aspect of the scaphoid here is very flexed, and you've got effectively between a line drawn along the volar aspect of the scaphoid and a line drawn along the two lips of this half moon, that is an increase in the scapholunate angle. This looks around about 80 degrees. Here the scaphoid is high riding, and this patient has a significant dysfunction in their wrist, and they're going to need that repaired. Okay. Again, just to name and shame the radiologist that said it was absolutely normal. Obviously there's a spectrum, right? So, and I really want to focus on the wrist in terms of x-rays here. So on the left-hand side here, you can see that this looks like a really, really high riding scaphoid. Again, here's the importance of two views, because you can see here that the whole carpus has dislocated off the back of the wrist. You can see that the capitate is sitting out the back of the wrist, perched on the back end over here. I cannot actually adequately see the lunate on these views, and the scaphoid is significant. The scaphoid itself actually is sitting dorsally dislocated and perched on the distal aspect of the radius, on the dorsal aspect of the radius over here. Okay. Here again, this is the importance of recognizing x-rays. This x-ray here on the left-hand side is the pathological one. This is a normal one. To the untrained eye who hasn't looked at a lot of wrist x-rays, that it is very easy to say, well, look, this left wrist x-ray looks normal. Okay, it is not normal. This is a perilunate dislocation. Okay, so if you look at the right-hand side over here, this is a lateral x-ray of the wrist where the capitate is completely dislocated over the back of the lunate here. All right, again, that you can see that there's significant swelling here. This patient will have significant stiffness and will have significant pain. If you suspect that there's something going on, ask, because there often is, okay? The swelling and the pain will tell you, even though this x-ray on the left looks near normal, this x-ray on the right here is grossly abnormal and you won't miss it. There obviously is a spectrum. This is another one. Here you can see that this has gone transstyloid. And again, the lunate here is actually sitting dislocated. This is a lunate dislocation volarly. And then it gets a bit more abnormal and a bit more serious. So here you've got a transscaphoid, scapholunate, basically perilunate dislocation. And again, hopefully by that reaches this stage, you're going to recognize that the scaphoid, basically the entire carpus, is dislocated off the radius. I'd like to segue into dislocations here. So that previous wrist was dislocated. Same for a finger, all right? Same for a wrist. As a broad principle, reverse the deforming force and pull it straight and apply a back slab. That will usually reduce the majority of your dislocations. I'm not going to say anything more on dislocations. Pieter very briefly chatted about infections. I would like to show the six different types of hand infections. These are the only types of hand infections that you get, okay? These are bacterial hand infections. You do get, obviously, your viral hand infections, your mycobacterial hand infections, but the common things that you see are going to be into one of these 6 different types of hand infections. You get a superficial subcutaneous, a paronychia, which is adjacent to the nail bed, a phelon, which is a pulp space infection, the web space, which is between the webs of the fingers, a flexor tenosynovitis, and a deep palmar space abscess. And those are the ones that you need to recognize early and refer on. So superficial subcutaneous, it can take various forms. The one on the right here, you can see that there is localized swelling, a small pus collection surrounding erythema. There is not significant swelling of that pulp space. There is not significant swelling of the adjacent pulp space. There is no ascending cellulitis. On the dorsum of the hand, this is a significant blister. There is some pus underneath here. There will be a lot of deepithelialization over the dorsum of the hand. This is still a simple subcutaneous abscess. This does not extend into the deep tissues. That is something that just needs a local block, an incision and drainage. Make sure that it drains nicely. Flucloxacillin as your empiric antibiotics for 7 days. If your patient is immunocompromised, put them on Augmentin for 7 days, as they often have, gram negatives or anaerobes. A paronychial infection looks like this. There is often a collection just adjacent to the nail bed. Sometimes these spontaneously decompress. What you need to do is ring block this patient, basically open the fold between the nail plate and the paronychial or the hyponychial or the hyponychial or the eponychial space, and basically allow that to drain. Again, 7 days of antibiotics. Check them at 3 days. A phelon is a pulp space infection. Although occurring in a very, very close proximity to a paronychia, it is a different anatomical space. So the fibrous septi that divide up the pulp space of the finger, these are infected. And the problem with this is it's insanely painful. It swells quickly. Patients often can't sleep at night, and they have this globular swelling of the entire volar aspect of the finger. It needs an incision over the midlateral aspect of either side of the finger, and you need to deloculate all of the sort of pus collection within the pulp space. It is very important that you do that. Otherwise, they can end up with osteomyelitis and sometimes an amputation. A web space abscess is typically like this. You often see splaying of the fingers. It is primarily a volar, or it is exclusively a volar problem. You make a small incision where I'm showing the arrow over the volar aspect of the hand here, when the patient is obviously under ring block, under an appropriate block. Make sure that you drain it adequately and place them on antibiotics. I cannot, or place them on flucloxacillin or augmentin based on your patient profile. You see the patient at 3 days, and I cannot emphasize how important it is to put them on adequate pain medication and anti-inflammatories and get them moving. The big thing in hand sepsis is stiffness, because it is neglected. Patients present to you in this wounded paw position and they don't want to move. Give them adequate analgesia, anti-inflammatories, and get them moving. This is what a flexitina synovitis looks like. There is diffuse swelling of the whole finger. It tracks up the finger, okay? There is intense pain. The finger is held in a position of slight flexion. There is a fusiform swelling over the whole finger, and this is quite a late stage, but this often results in amputation if left, if it has not been appropriately managed. You need to make an incision proximal to the A1 pulley, distal over where the FDP inserts, and you need to wash that out adequately. If you're unable to wash it out adequately like that, then you need to make incisions over the pulp spaces and drain it completely. Lastly, a deep palmar space infection. You can see that there's ascending cellulitis in this patient. This is another emergency as it tracks up the carpal tunnel and it goes into the proximal forearm. You need to do an adequate incision and drainage. Again, admit the patient, place them on IV antibiotics, and make sure that you check them in 3 days and get them moving. A last short note on the angry male is the fight bite. Do not let the sun set on a fight bite if you can, okay? If there is a puncture wound from fisticuffs, often the tooth has penetrated the joint capsule. You will get a host of bugs. This patient will need a debridement, samples, and sometimes even another relook in theatre in 2 to 3 days' time. Please take this very seriously, even though it is an innocuous injury, and refer it on. It needs a theatre episode. My last take-home message, and I hope I get to squeeze this in terms of the fractures, if it is distal, very distal, all you need to do is bandage it. Well, obviously, if it is open, then, antibiotics and stabilize it either with a bandage, depending on what you have available, refer it on if it is unstable and needs a K-wire. If it is at a P2 level, buddy tape to the neighbor. If it is at the P1 level, put a P1 pop. If it is at the metacarpal level, you put a volar slab or an ulnar gutter slab. If it is at the wrist, make sure that you haven't missed a significant fracture dislocation. If you have got a fracture dislocation, reduce it and place it in a volar slab. Thanks very, very much.
Kruger, thank you very much for a jam-packed presentation. It feels like we're going to have to do quite a few of these webinars, because I think really, really rich teaching on assessment and management. So thank you to both of you. I will just give us some final comments. So thank you everybody for joining us this evening. It was really lovely to have such a big audience from a number of countries. You will receive a link to the Zoom recording by the end of this week. And if you give us a little bit of time, the webinar will be made available on YouTube. And then you can also go and look at all our other past webinars that are available on the YouTube channel. Then just a reminder, if you're working in primary care of hand injuries, these applications are very helpful. The anatomy at risk application, which shows you all possible anatomical structures that can be affected in a specific area, and then the hand surgery source with a number of hand diagnoses, their management, their assessment, their management, and hand therapy, some hand therapy information. Our next webinar on the 2nd of June is also for the primary care of hand injuries for everyone involved in primary care. It's Wounds Back to the Basics in Hand Injury Care, and Dr. Chetan Patel, a plastic surgeon, will be sharing with us for that. Have a lovely evening, and we look forward to seeing you next time.